Hello, my name is Elefterios Paschalis and I'm an assistant professor of ophthalmology at Massachusetts Eye and Ear, Harvard Medical School. I'm also the director of innovation of the Boston Keratoprosthesis at Mass Eye and Ear. My work focuses on the prevention of blindness following eye trauma. My approach to the problem is holistic and involves the restoration of the injured cornea as well as the protection of the most vulnerable tissue, which is the retina. Ocular trauma is a real emergency that often leads to blindness. In the United States, approximately 2 million people per year experience some sort of an eye trauma that requires treatment. For this reason, it is the most common cause of blindness in the United States, with more than 40,000 new blind cases every year. This number is significantly higher in heavily industrialized countries. Demographically, eye injury affects mostly male between 20 and 40 years old. Eye injuries are responsible for more than 150,000 work-related injuries every year, leaving patients unable to return to the workforce for months or years. The estimated direct and indirect cost of eye injury exceeds $4 billion per year. Likewise, such injuries are very frequent also in the military, both on the battlefield as well as in the base. Reports from previous wars have shown a steady increase in percentage of ocular injuries during wartime, reaching up to 30% in operations Desert Shield and Desert Storm. Again, the cost of visual impairment is immense, and the burden does not fall on the federal government alone, but on the economy and the society as a whole. Based on data from 2000 to 2010, the total cost of eye injury in the military in this time frame was $2.2 billion per year, with the total cost of eye injury and vision impairment reaching $25 billion. This is without calculating medical cost of health care and medication, which is significantly higher in burn patients as compared to other age-matched patients. Of all the ocular traumas, chemical burns and open globe injuries are the most frequent ones. Chemical burns, however, are the most notorious in terms of vision prognosis and rehabilitation. The reason is that chemical ions tend to penetrate rapidly into the eye and cause damage to other important tissues such as the retina and the optic nerve. Chemical injuries also affect the limbal stem cells, which are responsible for maintaining corneal transparency. Therefore, corneal transplantation is associated with very poor clinical outcomes in these patients. Fortunately, recent innovations in artificial corneas have allowed the replacement of such badly damaged corneas with an artificial one. Our laboratory has been on the forefront of these developments, having 2 FDA-approved artificial corneas: the well-established Boston Keratoprosthesis, designed by Dr. Dolman, and a more recent innovation, the Lucia, designed by Dr. Chodos, Mr. Graney, and myself, all aiming to provide corneal transparency and restore corneal blindness. So far, the Boston Keratoprosthesis has been implanted in more than 16,000 patients worldwide, providing vision restoration when previous surgical attempts have failed. However, this also brought to our attention another major complication, which is often missed until it is too late. This complication is glaucoma, which leads to the gradual loss of retinal ganglion cells, the cells responsible for connecting the retina with the brain. Indeed, this unforeseen complication is a major one and can jeopardize any attempt to restore vision. It is clinically known that many patients lose vision from subsequent glaucoma after Boston Keratoprosthesis surgery. To address this major complication, we embarked on a scientific journey to elucidate the mechanisms that cause glaucoma after ocular injury. After 10 years of systematic research work in animals and clinical data, we made major findings that can potentially revolutionize the therapy of ocular injuries. Our work has uncovered the existence of a rapid inflammatory, pressure-independent mechanism to glaucoma. Tumor necrosis factor alpha, a potent inflammatory protein that causes cell death, was shown to mediate most of the injury to the retina. This protein is released by specialized immune cells of the retina, the microglia, as well as by a unique population of immune cells of the blood that engraft permanently into the retina after trauma. Translationally, prophylactic treatment with tumor necrosis factor alpha inhibitors is markedly neuroprotective of the retinal ganglion cells and can reduce substantially the risk of late glaucoma in animals. Additional studies have confirmed that this immune mechanism is not unique to one type of injury, but to all types of ocular injuries, including that from surgical trauma. In conclusion, ocular traumas, including surgical ones, can cause indirect damage to the retina, demonstrating an immunological link between the anterior and posterior eye. Prompt inhibition of tumor necrosis factor alpha with antibodies is highly neuroprotective, and when combined with an artificial cornea, clinical outcomes could be substantially improved. Most important, these findings may also have clinical implications to other neurodegenerative diseases of the central nervous system.